board workshop, particularly focusing on the prevention agenda and the great work that's going on across all of our geographies, working with our communities on different healthcare issues. And then we were very grateful for Julian Kelly, the Deputy Chief Executive and Finance Director of the NHS England, joining us to talk about some of the challenges we all face. So a busy morning already. I want to do a few welcomes. Welcome to Alex Moran, Catherine Driscoll, who are both joining us as Associate Neds at Worcester Acute. Delighted to have you on board. And to Robert White, who's joining us at Swift as our new Chair of the Audit Committee. So welcome, we're all looking forward to seeing you. And this is the last four-group board meeting, I think, for John Barnes down at Wye Valley. So John, thank you for your service. We'll be seeing you in different form. I wanted to just say a few words of thank you also to all of the volunteers across the foundation group. We are blessed to have so many members of our local community who volunteer in different situations and different circumstances. Our League of Friends in particular, their fantastic charitable fundraising work that go on around our geography, particularly, for example, at the George Eliot, where our canteen, cafeteria, coffee bar was organised by them. So enormous thanks to all of our volunteers across the foundation group. But I also wanted to say a few words, given the very distressing social unrest which we've seen in recent days, and the impact this is having on many of our staff and many of our communities. If I could ask you to go on to mute if you're not on mute already. On Monday, Glenn and I reached out to all of our staff, and I would like, Glenn, for us to attach the emails. I know they were slightly different to each of the different trusts, but they went out to all of our staff. If we can attach those minutes as those emails as to these minutes as part of the public record. And we also reached out to all of our chairs of the BAME network to confirm our unwavering support to all of our colleagues who are feeling anxious during these distressing events which we are seeing on our TVs. The values we promote in our trusts of inclusivity are not mere words. They are a statement of who we are, what we stand for, and what we believe is right and what we believe is wrong. We believe racism is wrong. We believe sexism is wrong. We believe treating people with a different religion, a different sexual orientation, a different gender, a different background to you is wrong. We believe we should all be treated equally without fear or favour. We believe in the richness of inclusivity. We believe in encouraging and promoting talent, hard work, and those who demonstrate these behaviours. We believe in kindness and compassion to all. We believe in being proud of who we are. We believe in standing up for those who cannot or are afraid to stand up for themselves. We will not tolerate bullies, racists, or bigots of any kind, whether that's amongst members of the public or members of our staff. That statement describes who we are, and we're proud to be the foundation group of NHS trusts. So for everyone at the moment who is anxious in any way, we have set up mechanisms within the trust to support you, and please do use them if you need to. So without further ado, we'll move on to the main business of today. First of all, apologies for absence. We have apologies from Phil Gilbert, Pramjit Gill, Simone Jordan, David Moon, Joe Newton, Lisa, lovely to have you again deputising, Sarah Shingler, And Alison, lovely for you to be with us. And we have apologies from Jules. Any other apologies, Sarah, that I have missed? Please let me know.
Yeah, we've also got Julie Holder, Ian James, Zoe Mayhew, Karen Martin, Richard Haynes and Rosie from George Eliot.
Okay, thank you for that completion of the list. Any new declarations of interest? Anil, I think you had some.
Yes, thank you, Chair. Two changes. One is I've completed my term with Canal and River Trust. And second one is I've been appointed the non-executive member at ICB Leicester, Leicestershire and Rutland for health inequalities and communities.
Fantastic, Anil. Congratulations on that appointment. And Sarah Rastrick?
Mine isn't a new declaration, but just for transparency for the minutes, I'm a practicing GP in one of the areas, one of the ICBs that the Foundation Trust are in. So if we have discussions pertaining to work relating to primary care, especially today in collective action, I'd just like that to be noted. Thank you.
No, and we're blessed as well to have you on board with us, Sarah, as we are with David at Swift. And Robert White, I think you had a declaration of interest you wanted to mention to us.
Yes, there was some accountancy advice provided to Swift by RSM UK, and my son is an accountant with RSM. He tells me he doesn't work on the public sector side of the organisation, but nevertheless he is employed by the same accountancy body. Okay,
great. And Karen Martin's just like Lazarus mentioned in the chat box that she's risen and she's actually with us in the meeting. So Karen, your apologies will be stricken from the record. The minutes of the meeting held on the 2nd of May, were there any points of accuracy on those minutes? Please raise a digital hand. Okay, I can't see any hands raised, so we'll then move on to public actions. The first was for the Chief People Officers to discuss ways to further support staff and members of the public with national schemes and safe words regarding the Sexual Safety Charter. That has been done, and we're linking into our regional social partnership forums as well. One of the things that horrifies me at the moment is the level of sexual abuse, particularly towards women in the domestic environment. And I know in each of our geographies, we are actively involved in supporting anyone who suffers domestic abuse. Then from our COOs, looking to recording theatre utilisation data by cost per minute. That's in the process of being recalculated, so look forward to that. Having said that, Julian Kelly did call out the fact that I think Swift is now the third most productive trust in the whole of the country, which I think is a testimony to all of the work, which isn't just in Swift. Swift benefits from the inputs of different bits of the foundation group in driving its productivity agenda, and it works both ways. And Andrew Parker and Harkamel will be talking about elective productivity later on today. Then also the COOs to look at variations in the performance report around theatre utilisation. We'll come back to that in this meeting, so look forward to that. Then Catherine was to provide an update on why the George Eliot was now a liar for cancer diagnosis. And where are we with that, Catherine?
Yeah, sorry, Russell. The person who was undertaking that for us has been unwell and away, so that's going to take place this month instead.
Okay, look forward to seeing that. If you can circulate it to us, Catherine, once you've got it, that would be fantastic.
Will do.
And then Vicky and colleagues were working through the reporting structure of the different work streams. And I'm not sure Vicky's on the line with Vicky. You are on the line with us.
I'm here.
Can you just tell us what we're going to do, because we're losing you? It's your last group board meeting as well, so we wish you well for the future. But on this one, Vicky, what's happening with the group informatics proposal?
Thanks very much, Chair. So from an informatics perspective, business analytics, we're going to retain that leadership piece with the Worcestershire team. Me, Madeleine and I are going to work through the rest of the digital data and technology portfolio in terms of what that might look like in the future. Thank you, Chair.
Vicky, as we wished you well for the future in your new role, if it doesn't work out, there's always a safe port in the foundation group. So don't hesitate to reach back out if...
Thank you. I'm going to miss you a lot, so thank you very much.
No. Glenn, is there anything you wanted to add to the, or anyone else on the matters arising? Anything you feel I've missed? Please raise a digital hand. And similarly, Glenn, on the overview of our big move discussion and the workshop this morning, is there anything you think I missed in my summary, or anything you'd like to add to the words I said at the start?
I don't think you missed anything, Chairman, but I'd just like to add to what you said. I think it was great to see the level of activity around the prevention agenda across the group. Obviously, we identified embedding prevention as one of our 4 big moves. Worcestershire Acute colleagues are testing those big moves with all of our workforce there, but actually they've got alongside it and doing some great work in Worcestershire as well as across the group. And I think it's particularly challenging at the moment because the public health funding sits within local authorities. Their budgets are really quite challenged. So for us, we do need to make sure that we try and carve out more of our actions towards prevention. So it's good to see it being included in improvement training, and it's also good to see the challenge that goes into individual business cases to ensure that they have prevention embedded within them. So really pleased to see that.
Yeah, I know she's on the call, so she'll correct me if my recollection is wrong, but I think Dame Julie Moore talked in a different forum about how the payback was 6-fold effectively, that with prevention, it is so effective in producing better health outcomes. You get 6 times your money back effectively compared to not doing prevention and then having to treat in a more expensive setting, let alone an acute setting. So prevention is economically sensible and increases the quality of lives lived, which is part of the objective, I think, of the human experience. Okay, thank you, Glenn. We'll move on then to the performance review and updates and the Foundation Group performance report. Over to you, my Managing Director colleagues. Jane, are you leading us off today?
I am. We just go in the order in which we're on the performance report. So as always, I usually do take the report as read, but something that I'm really worried about, something I've got a rising concern about, and then something that I'm proud of in the sense of good performance. So my real worry continues to be around our congested emergency department and hospital. So we are regularly in a position of having 50 patients extra to our bed base, some of those in ED, some of those boarding patients, and that has continued right through the summer so far. So that's a real cause of concern, and it is the highest thing on our risk register, therefore is our top priority. Things are going to become more difficult over the next couple of months because we're having to decant our A&E department to do a lot of refurbishment and life cycle work. So there's a big plan in place for that, but that's going to make things a bit more pressured during September through to the middle of October. So we've been doing a lot of work on understanding the drivers of that position. And we've really looked at the last couple of years. We haven't taken this back to pre-pandemic because so many things have moved on. But if we just look back over the last couple of years, demand has grown very significantly. So if we look at our emergency demand, both seen on the day and in admitted patients, so these are the most sick of our patients, that's 12 extra patients every day. If we just look at the admitted patients, that's 5 extra every day. So with a length of stay of around about 6 to 7 days, I mean, that is the 30 patients we're seeing boarding on our wards. So, and then we also looked at length of stay, and I have to say I was expecting to see a length of stay increase alongside that, but that hasn't been the case. I mean, it's quite interesting because overall our length of stay is the same as it has been, which benchmarks relatively well. It's not top in class, but it's certainly in the top half. But what we have seen in that, actually, our length of stay for some of our younger patients under 50 has gone up a bit, but our length of stay for our older patients, those over 70, has reduced with some of the things that we've been doing with our frailty models. So there's some interesting data in that, but the question is then what can we do about it? And we're looking at all three areas of what can we do on demand reduction, what can we do on internal hospital processes that can always be sharpened up, and then what more can we do on discharge. I'm not going to go through all of the different things that we're doing because there's a whole set of programs and projects and pieces of work on that. But I was just going to draw out two, and they do relate back to the conversations we had earlier today. So first is around that increasing the capacity of community services, but also bringing them all into a much more simplified model. So in September, we're relaunching our community referral hub, which will have all of those services from virtual ward to urgent community response to OPAT to hospital at home services, which are quite complex for referrers, whether they are discharging into or admitting to from the community, to make it much simpler and increasing the capacity in those. So we think there's significant opportunity in there, both for earlier discharge and for admission prevention. And then the other thing we've done is we've really challenged our integrated neighbourhood teams. So those consist of our PCNs, so our GPs, primary care, and our community services, as well as voluntary services, to do what they can do on the prevention agenda to reduce the number of patients coming in. We've given them a target of one PCN, one admission per day per PCN, to reduce that back down. So that's things like how we improve the care of people in nursing homes, how we do more proactive care for those who are frail and coming towards the end of their lives. So those are two big pieces of work which will work on demand reduction. So I was probably going to move on next to the area that we're proud of, because it plays back into that congestion, because we understand how dangerous that can be for patients, and so there's a lot of mitigation that's gone in around those congested areas. And whilst it's not the only indicator, patient experience, staff experience are really important. Actually, mortality is a big indicator, and we've seen some of those national studies that show mortality rises as congestion rises. And actually what we've seen is our mortality has been going down, and it is now below 100. That's the first time it's ever been below 100. So something to really be proud of. And that's all of our teams, all of our clinical teams working on improving pathway management and the mitigation that we're putting in around trying to keep patients safe when things are congested. So some good news on that. And the last area I wanted to talk about was the thing that I'm concerned about. It's a rising concern, and it's really about our waiting list size. So in terms of our waiting times, we're sort of doing that tail gunning of long waiting patients, and whilst at the moment it looks like we may have a few outstanding at the end of September, we're working hard on getting down to that 0 people waiting over 65 weeks. But actually, if you look at what's happening to our waiting list size, since in the last 12 months, it's gone up by 9%. So we're putting on more people onto our waiting list. So we've been looking what's happened to referral patterns. And last year, our referrals went up by 5% over our 19-20 baseline. This year, the first quarter, they've gone up by a further 9%. So we've got a 14% increase in our referred demand. So there's a lot of work for us to do with that on the referrers. Some of those are internal, some of those are our GPs. But if we carry on at the rate that we're going, with that referral staying at that level, and the activity that we're doing, which is improved, and it is broadly meeting targets, and all the productivity work, we're going to end this year with the same size of waiting list as we started it with. And what we need to see is a reduction, because our that long wait problem will just catch up with us as that wave comes through. So really concerned about level of referrals and the size of the waiting list. So that's the other area that we're looking at.
That's great. Thank you, Jane. Questions or perspectives to Jane before we move on? Glenn?
Yeah, thank you, Jane. I know we're going to look at elective productivity a little bit later on, so I won't go into the nitty-gritty of that. But I think one of the things that we're going to see soon is a elective recovery plan version 2 nationally. And I think one of the concerns that people have at the moment is that within our waiting list, there's quite a lot of patients who are referred into secondary care who then need diagnostic tests. And now that we have more diagnostic capacity, particularly with community diagnostic centres coming on stream, there's a question for us about whether there's an opportunity to have more direct access for primary care to some of those tests that would speed up access for those patients and maybe take some of those individuals off the waiting list. So I think one of the things I'd like us to have a look at, maybe this is one that we could bring back another time, is the relative volumes of direct access that are going on across the group to see where the best practice is on that. I think that would be a useful one to analyse.
No,
interesting, Glenn. I mean, and we do a huge amount of direct access, particularly for imaging. So it'd be really good to see those benchmarks. But you know, for example, we've got direct access for all MRIs, which certainly isn't the case in most parts of the country. So there's lots more for us to do.
Super, thank you, Jane. I think just as a general point, it's important that we make sure we capture all of the action points in the minutes and make sure those actions are followed up at the individual boards. If I can ask colleagues to use the chat box as far as possible for questions, it just allows us to keep the pace going, given how many people are on the call. So we're now therefore over to Swift and Adam.
Thank you, Chair. I'm going to start very briefly, as usual, by talking about ED performance and flow in the hospital, because this does remain a real area of focus for us. That being said, it's a similar story to that which I've reported here before, and I think it's very clear in the data. We have seen really sustained increases in ED demand during the first quarter of the year, and in fact are now a bit of a new normal in terms of the high level of demand, particularly for type 1 attendances. And as I've said here before, it's driven in part by out of area, but we've also seen some really significant changes in system in Coventry and Warwickshire, and perhaps taking on more activity than we have previously, and that has impacted on performance as it is shown in the data. That's all I want to say about ED today, but it does remain that area of focus for us. In terms of the other areas I want to highlight, I want to start with outpatient service, because there's some really good work going on here, and certainly the team have led a whole load of work around outpatient redesign. I want to particularly comment on DNA rates. So our comparative position nationally for DNA rates remains good. We're in the top quartile, but we believe there's more that we can do. So we've been working with Deep Medical on a really innovative use of AI tools for booked appointments to analyse for potential DNAs. And we're then coupling that with work with volunteers through Helpforce to pilot an approach of direct contact with those where we feel a DNA is likely. So early days for that work, but I think a really innovative use of both technology and our volunteering services to address a known challenge in our services. We're also doing some really good work around analysing DNA rates and health inequalities, to understand whether there's more we can do. And I think the next step of that work, now we understand the data a bit better, is to move into the kind of so what area. What are we going to do with addressing that? I think the other area in our outpatient services is PIFU. We remain in a really positive place for patient-initiated follow-ups and are in the top quartile nationally. But we have further work over the coming months to roll this out to more of our services. So we can expect in the second half of the year to see a further increase in those PIFU rates, which we know are better in terms of managing demand on services, but also better for patients who get easier and better access to services when we need them. So really good work in outpatient services. In terms of areas of concern, we still remain concerned about our cancer services, and this still remains an area of focus. We are seeing sustained very high referral rates, much higher than we've seen in the past, and ongoing increases year on year. In terms of the fast diagnosis standard, we've seen some real improvements there, but our 62-day standard remains a challenge. There has been some improvement on the May data from April, and it certainly remains an area of focus. But in breast service and dermatology services in particular, we see challenges, and dermatology, because of the volume of referrals we're getting, we are dealing with a backlog. The numbers there are big, and we are working to manage that. Finally, I want to comment on waiting lists. We, again, as I've mentioned here in the past, we have had a real challenge around orthodontics, and this is both a regional and national challenge in terms of availability of orthodontists. We've been working really closely with the ICB and NHS England to address that, and I'm really pleased to say we've got some good plans in place there now for starting to tackle that backlog. And as a result, we've seen a real reduction in 78-week referrals. But also our 65-week referrals now have reduced to 58, the majority of which are orthodontics. And again, because of that work we're doing, we are seeing a reduction. In terms of other areas of waiting lists, we've had a real improvement in our diagnostic waiting times. So we started the year at 67%, and we're now up to 87%. That is largely driven by reduction in non-obstetric ultrasound waits, which we put some real focus on and have managed to recruit additional staff to support. Challenges still remain in terms of the high demand, and I think one of the areas we're really watching is our CT and X-ray demand. Our expected growth for the year was around 8%, but we're currently up at around 14% growth. So we're keeping the performance in the right place at the moment, but growth levels like that are clearly hard to manage with the current levels of resourcing and access to the scanners. Finally, we've seen our waiting list numbers generally start to flatten after the increases last year, and in fact are seeing reductions overall. And I think that's a reflection of the great work we're doing in our elective services. So those are my points for this month. Thank you.
Thank you, Adam. I'm just conscious of the time. Great summaries. Great question from Paul on to the MDs about the fit to sit areas. So if someone could answer that. Glenn, anything you wanted to add before we move on to Catherine?
Yeah, I really love the comparative performance data that we see in these reports. The one, Adam, that maybe looks a little bit concerning is the 52-week wait position at Swift, which looks flat, if not rising. Whereas if you look at the profile of Worcestershire Acute, it's a falling position. So it's just that kind of concern that are we doing enough at the tail end of the waiting list in order to address that challenge?
Yeah, I agree, Glenn. Our focus has certainly been on the long waiters, and obviously some of those numbers are impacted by mutual aid and other work we're doing. But I think we can take that away and perhaps give a bit of a trajectory for next time.
Yeah, let's make sure that's picked up in the next Swift board. That would be great. Thank you. Moving on then to Catherine. Catherine, over to you.
Thanks, Russell. Well, I was worried that you'd misspoke earlier when we were talking to Julie and Kelly about performance in emergency departments and highlighting Swift, because if you look at the June data and the year-to-date data, it's George Eliot that has the better A&E performance. But, and Adam knows I was going to say that because that's part of, as Glenn says, comparing the data so we can compare and compete to some extent with one another. But what I would like to say about this is there are some areas that we've got to focus on here because we're still not meeting the watered down constitutionals target, and we're a long way away from where we really want to be, which is back at 95%. And actually that performance puts us at about 50th out of 142 trusts in terms of nationally. So there's quite a bit of improvement for all of us in that regard. And to address Paul's point in the chat, we are still seeing quite considerable delays in the emergency department. We saw 51 patients wait over 12 hours from the decision to admit to them actually getting a bed in the organisation. And that's much improved on the months previously, but that's still a concern to us. Why have we seen an improvement in our A&E performance in this in June? Well, the reason that I'm going to link it to very strongly, I'm not going to stop going on about this, is our medically fit for discharge numbers. We worked really hard with system partners in the ICB, in social care, Swift Community Services, around tackling that number. We've at the end of May introduced 2 calls a day to follow up on patients who could leave our care to make sure we had plans in the community for them. That had led to a reduction down from about 60 patients in the organisation medically fit for discharge. At the lowest point in June, that was down to 40. We sadly saw that number increase again in July and improve again at the beginning of August. So that really has a direct impact on those other things. Where I will give our colleagues in Swift the plaudits is around the ambulance handover delays, because there's more that we need to do to improve. We used to be one of the best organisations nationally in terms of ambulance handover delays, but we haven't seen that improve in the same way we've seen some of the other things improve. So that will be an area for focus for us going forward. One of the things I am most pleased about, which I was once most shocked about, is our sickness levels in the organisation. When we first did our first 4 boards meeting and looked at the data, George Eliot had the highest rate of sickness across any of the 4 trusts in the group. That number is now 4.6%, still higher than our target, but we've put really hard on vacancy reduction, on the feedback from the staff survey, and working with our staff, listening to them. And the other metric that's not on here that I must celebrate for the George Eliot board is in June, our appraisal rate was 87% of our staff. We have struggled in the entire time I've been at George Eliot to get that number over 85%. So it's really thanks to colleagues who've had their appraisal, colleagues who've held appraisals. That's been really hard to shift that dial, but we're now seeing a sustained improvement in that. In terms of our cancer performance, we have seen a sustained improvement in our faster diagnostic standard. Again, that was an area of real concern to us earlier in the year. We still, like Adam is saying, have got concerns over our 62-day performance. There is a lot of focus going on in there. We hope to see that start to improve soon, but what we have sustained in the faster diagnosis standard will support the ability to treat patients who are diagnosed with cancer within 62 days. And lastly, for us on the electives, we are seeing sort of maintaining. We've seen a slight reduction in 52-week breaches. That number is 220 odd, is around where we are at the moment in July, working very hard to clear that. We've got 23 patients waiting over 65 weeks, and our ambition is to try and clear those long waiters by the end of September. That is challenging for the teams, and as Jane says, you cannot stop thinking about the patients being added onto the list. It's not good enough just to treat the long waiters. We have to treat more patients that we are being referred to make an impact. But those are areas of positivity for us at George Eliot at the moment.
Catherine, as ever, great summary. Glenn, anything you want to ask? Can we please the points in the chat box are being answered? Thank you. Glenn?
In my desire to be even-handed, I'll make a comment on each of these. As you quite rightly say, Catherine, some really good indicators there. 62-day cancer is the one that we're obviously quite focused on at the moment. Just to reassure anyone looking at this who's a member of the public, that indicator, it triggers when you treat a patient. So we are currently treating some of those long wait patients, which has led to a slight deterioration in our performance, but we are dealing with that tail of the waiting list, and so I'm reasonably confident that should start to improve as we treat those patients through the system.
Yeah, no, great. And Catherine's point about medically fit for discharge is a consistent challenge across the whole of our portfolio of trusts. It is a waste of money for us to be looking after people when they're medically fit for discharge. With system partners, we must find better ways to ensure people get home as soon as they're ready to get home. And that allows us to stop the boarding and to drive into the elective waiting list. But we do need system partners working with us to find solutions to those medically fit for discharge patients. As soon as they're ready to get home, they go home. And so really good progress there. But as you say, Catherine, still around 40. Last but by no means least, Stephen.
Thanks, and I'll pick up on the productivity challenge and say what I can as quick as I can in the main points. I'm going to pick to two main themes really, and those two main themes pick up on kind of quality, performance and finance and drive it. So the first one is around, we've touched on a bit around our urgent care performance, and in particular the role that occupancy is playing with that. We've done a very detailed analysis that we've shared with our board before around what contributes to that and what we've got the biggest impact on. And we are working with our health and care trust partners around different service offer for particularly general medicine patients who contribute significantly to that. The other contributor that we are working through very quickly is we've had two areas of capacity out. We've had one that was unfunded, and with our financial challenges, we've had to work through that. But also some of the site works that I think Jane has mentioned, we've got a programme of that going through up until winter, so we're carefully working that through. And to put a bit of a trailer that we're hoping to bring to a board development session at Worcester Acute is some work that we're doing with public health, that we've been able to do an analysis of emergency missions by 300 to 400 households. So this goes much deeper than place, and we can now actually say the top 10 grouping areas that are contributing to our emergency missions, and we've got a programme of work with them and our ICS colleagues around what we can do differently there. The other bit that I wanted to pull out was around productivity, and in particular how that links to our elective and cancer performance and the overall financial performance of the trust. And you will see in some of our workforce metrics, the work that we've been doing to reduce agency. So we've really driven down a lot of our high cost agency, and we are holding our elective plan where it needs to be. And some of that is coming through the cancer numbers as well, in terms of the numbers that we're being able to treat, particularly our two most challenged specialties previously of urology and dermatology. And for context, in urology, I think for the last couple of months, we've been within the top 15 nationally in terms of numbers that we're actually treating. So we have a significant demand within Worcestershire, but fortunately we're finding ways to meet that. So they're the overall headlines that I just wanted to pull out for us.
Thanks, Stephen. Great to see the new urology facility over at the Alex, and we're making strong and steady progress at Worcestershire. So thank you, team, for those green shoots. Now, Glenn, in his desire to be equitable, is now going to make a point. Glenn.
Yeah, I mean, there's some really good improvement. I mean, the cancer performance improvement has been really marked, and it's great to see the organisation move away from national monitoring on that. Obviously, there's a number of areas that we're working on in the background. I think one of the ones that still stands out for me is the level of the sickness levels in the organisation. So I think reviewing the staff support and the underlying trends beneath that is one of the things that we're continuing to do some work on.
No, great. And it was super, Stephen, to see Her Royal Highness Princess Anne visit our new ED department, and thanks to Wendy, Dave and Claire, who escorted Her Royal Highness around, and Richard Haynes for everything in making the day a success. I think that was great, a great uplift for the team. Stephen, a couple of points in the chat box for you to answer. And Chelsea, can I just ensure that when we do the recording of the 4 board meetings, we allow the chat box to be seen by members of the public, just so that we enable members of the public to see the answers to some of the questions and the questions in themselves being asked. So I think we are ready to move on, team, if there are no other points, onto the finance update and productivity update. And I think Katie and Hack, you're going to lead on this, so over to you.
Thank you, Chair. I've just shared my slides and I'll start off and then I'll hand over to Katie. So the presentation is in two parts. So the first bit that I'll cover, we'll look at the financial position and the CPIP planning and delivery, and Katie will talk about some of the productivity comparisons across the 4 organisations. So if I start off by looking at the overall financial position across all 4 organisations, we've got some very challenging financial targets to hit across the group, and that is reflective of the national picture as well. There's lots of numbers on this slide. I'm not going to go through all the numbers. I'll just focus on the bottom line across this table. So all 4 organisations are reporting deficits at the end of the first quarter. But in terms of full year plans, Swift and George Eliot are planning on delivering small surpluses by the end of the year, and Wye Valley and Worcester Acute are planning on delivering deficits of £31 million and £57 million respectively. So that's just to give you some context of how the year-to-date position potentially compares with where we need to end up by the end of the financial year. The key challenges that we're facing, you've heard some of those already in the previous agenda items. So things like the urgent and emergency care demand are clearly impacting the additional capacity we have open, so impact on costs there. But also got inflationary pressures above the funded levels. We've also had impact of industrial action, which impacts expenditure as well as elective recovery performance, and very high CPIP targets. And you can see from the variances across the bottom line there on that table that Wye Valley has been particularly impacted by some of those challenges. So if I now move on to the CPIP targets, so delivering our financial plan is very much dependent on delivering the CPIP targets. And as a percentage of turnover, we have some very challenging CPIP targets across the group when you look at the level that have been delivered historically. But if you look at the numbers on this slide, all organisations have done well to identify projects for the vast majority of the target. But the proportion of those projects that are fully worked up does vary quite considerably across all 4 organisations. So there's more work to do in terms of working up those plans fully and getting them into delivery mode. Each organisation has mechanisms in place to support and oversee the delivery of their CPIP targets, whilst connecting with other pieces of work like the improvement programmes as well, and making sure that we're not duplicating effort. And we're also learning from each other as well. So we're sharing our CPIP plans as well as our approaches to planning and delivery of our CPIP targets. Now, if we go on to look at some of the a couple of key elements of our financial plan delivery, so temporary staffing costs, and also on to look at our elective recovery performance. But first, looking at our temporary staffing costs. Over the last few years, we've seen our temporary staffing expenditure increase as a proportion of our total pay bill. But more importantly, in recent months, and particularly over the last year, we've seen reductions in temporary staffing. And particularly at George Eliot and Wye Valley, we've seen a significant reduction in agency expenditure over the last 12 months, but there is a general decline in temporary staffing costs across all organisations. So we can see some of the actions that we've been taking having an impact on that. So recruitment to vacancies, improving rostering, improving controls on temporary staffing, as well as working to reduce the rates that we're paying for agency staff in particular. So lots of effort has gone into delivering some of these improvements. But if we also kind of look at the next slide, there is more to go at. So NHSE has some rules for us to work to. We can see in terms of compliance against the framework, we generally have very good compliance across the group in terms of using framework agencies. But there is more work to do on price cap compliance. and there is work going on across the systems and within systems by procurement colleagues looking at the agency rates that we are paying, to working together with partners on reducing those rates. There's also wide variation against the agency ceiling across the organisation, with Swift and George Eliot very close to their agency ceiling, but Wye Valley and Worcester Acute are some distance from the ceiling. But I think it's important to note that the plans that Wye Valley and Worcester Acute have agreed do not get them down to the agency ceiling anyway. But that doesn't mean there is more for them to go at for next financial year. And just wanted to flag a couple of particularly good elements of performance. So George Eliot in June was below the agency ceiling, and that's a really good performance considering we were double the ceiling about a year ago. And Worcester Acute are £1 million ahead of their plan. So again, really good performance there as well. If I move on to my final slide before I hand over to Katie. So another key element of delivering our financial position is in relation to productivity and elective recovery. So we have all set internal planning elective recovery targets that are above the national requirement. So what it does do is demonstrate a degree of ambition here for us to improve productivity. These targets do vary between organisations because the variation in our baseline productivity levels, or in other words, different organisations have got different have got more to go at than other organisations. So you do have to kind of look at the historical productivity levels as well as the comparison with pre-COVID levels, which is what you see on this slide. The year-to-date performance across all organisations is pretty good from a financial value perspective, and it's higher than pre-COVID levels. There's very good performance. That's very good performance considering some of the challenges that we've already heard about, particularly around the urgent and emergency care demand. But we're still working to continue to improve ERF performance further. And a couple of examples just to draw out. So Wye Valley are expecting performance to improve with the opening of the elective surgical hub, and George Eliot have set an internal stretch target to get to 143% of pre-COVID levels of activity, and that's in an attempt to mitigate some of the risks that we're facing. So so some of those improvements are in addition to the improvements that are being made across the group as well. So there is a productivity work going on across the group as well. So lots of, I think, good performance in terms of some of the key numbers on temporary staffing and elective recovery, but nonetheless a very significant financial challenge for us to rise to. But we can see some of the key numbers moving in the right direction. I'll hand over to Katie now.
Thank you, Hack. Really helpful. So if you move the slides for me, lovely. Thank you. Stephen.
Katie, just before we move on, Hack, could you go back a slide for me, please? Any questions or perspectives to Hack, Glenn?
Yeah, I mean, just a couple of things. I mean, firstly, the way this data is presented is really helpful. Thank you. And it's good to see the comparisons. I mean, firstly, just an observation. It's great to see the progress on reducing agency spend across the group. But if you just take that month 3 position and gross it up for a year, that's over £68 million worth of agency spend across group. So there's still a big opportunity there. It's just that £44 million worth of schemes being worked up across the group. I think the challenge for all of us, and this isn't necessarily for the chief finance officers, is how we turn that into actual delivered schemes, because those schemes will also have some assumptions about when they start in those values, and we don't want to be slipping on the delivery, because it's really important to focus that. I don't know if any of the CFOs have got any comments they want to make about how we can speed up the realization of some of those ideas.
If I can start off, so part of it is focusing on a few things. So that's the discussion we're having internally around what are those few things, very targeted areas, so the big hitting values that we're going to focus on. And the other bit is connecting it to pieces of work we're doing already. So in terms of our improvement program, we're making sure we are not duplicating effort and we're targeting our efforts. So that's some of the discussions we're having and making sure we've got that alignment across our improvement program and our CPIP program. I'm doing a few things really well.
Can I suggest finance colleagues pop the answers, Glenn, into the chat box? I think that would be good. But I similarly share your anxiety that I think we haven't got as much grip in all parts of the foundation group on CPIPs and income allocation as I would expect this far into the financial year. So I'd really like that to be demonstrated. We're now in August, team, and we should have a financial grip on our CPIPs. Glenn, I wanted to make one other point, but your hand went up.
Yeah, it's just a concern. Obviously, this is a public meeting and members of the public can't see the chat, and I don't think there's a function that we can allow them to, Chairman. So I think we just make sure we capture those actions in the next board meeting. Okay, and the individual board. Sorry, Glenn. Is there no way, Chelsea and Sarah, I'll leave it with you, that we can get the chat box opened up, because there's nothing in there which causes me an anxiety. My other point was on the elective recovery work. I think it's quite exceptional, the level of performance that we're delivering. If I take, even though it's a yellow, the George Eliot at 128.6, very, very well done to that team. And I look forward to seeing Wye Valley accelerate through. Elective recovery income can be our financial salvation, but the only way it can be our financial salvation is if we get the medically fit for discharge patients home, so we've got beds that we can do the ERF. I'm simplifying it, but you take the principle. The other shout out is to Harcomel and Sophie. To be achieving almost 118% year to date when we are doing so much work on site is quite extraordinary, and I think illustrates the talents of Sophie and Harcomel in juggling the different bits of that jigsaw to still make it an extremely effective engine room for elective work. So well done. Katie, over to you for the productivity bit of this presentation.
Thank you, Chair, and it flows quite nicely from one section to the other, doesn't it? Because of course, the more we deliver activity, we need to do that by being productive and not just by incurring more cost to deliver it. So it feeds really nicely into the second part of this deck today. And so, as we've said, the focus is on how we improve our performance through productivity, and the question really is, how do we assess are we being more productive, and how do we know whether we're improving or not? So there are a range of tools available to us, and some of those are included in these slides today as a bit of a snapshot and an example of some of the productivity metrics. It's like any metric in isolation, none of them are perfect, and we do need to exercise caution in using them, particularly at times in terms of comparing organisation to organisation. But in terms of using those metrics to triangulate across a range of metrics and to look at trends, they can be really helpful. And what we're also seeing this year, and colleagues will be aware, is that across the kind of national picture, there's a range of national tools also being developed and more intelligence being made available to really support us in understanding our productivity challenge, and the teams, both the COOs and the finance community, are engaged in those. And what this slide really tries to do is draw out a couple of those metrics. So some of the national benchmarking that's available through the Model Health system, which attempts to look at a fairly crude but a measure for implied productivity and workforce productivity. We know they're not perfect. They look at cost growth relative to activity growth and workforce growth compared to 1920. They include all costs and all workforce, but not necessarily all activity. So there are some nuances in the indicators. But I think what they reflect is that the NHS as a whole has had a productivity reduction compared to pre-COVID, and has seen significant workforce growth, as Julian touched on in the workshop this morning. There are some positive areas of performance for some of the group trusts, and there's clearly some areas of opportunity for us to explore and to consider the extent to which we can improve our productivity and change some of those metrics to a more positive view. The cost per weighted activity unit, which is the second part of the table on there, attempts to standardise activity and unit costs so that there's a comparable measure that we can use. And as an example, as we continue to ramp up our ERF performance and reduce our temporary staffing costs, so our 2 areas of focus for productivity, we would expect our cost per wow to decrease. And that would be the way we would assess whether we're delivering more better value. So those trends over time can be really useful, but we do need to be cautious in how we use them. Next slide, please, Hack. Thank you. Alongside some of those national tools, then we've developed some local measures, because one of the challenges with the national tools is that they're not necessarily refreshed as regularly as we might like to support our operational delivery. So each of the group organisations has developed a local version of the cost per weighted activity unit. And indeed, behind sort of the headline metric, there are a range of other metrics linked to this, which are then typically used through each organisation's productivity board to really kind of support that deep dive into performance. And we know as another example, so Swift have shared some of their productivity by specialty work, which builds on this with the National Director of Efficiency. And so there is that learning within group, but also how we share some of what we're doing more broadly. And what this really tells us is that each of the trusts has shown an increased cost per weighted activity unit. You can see quite clearly on the charts the initial big spike when COVID hit, and of course our activity significantly reduced, but costs significantly increased, and how we've recovered over time, but that our cost per unit remains at a higher level than it did pre-COVID. So that might imply a productivity deterioration. Next slide, please, Hack. Another lens through which we can look at our productivity and how we're performing is through the National Cost Collection Index, so what used to be called reference costs. And effectively it compares providers' costs of carrying out activity and puts that into an index to measure the relative cost adjusted for case mix. What this tells us is, so Swift and George Eliot are below the national average index of 100, so are performing strongly. Worcester is broadly at the average and Wye Valley is above the average, and we know that that is largely influenced by our rurality and some of the excess costs that we incur as a result of that structural challenge. We also know, though, that the sort of national tariff and the payment mechanism doesn't necessarily equal that index of 100. So even if we deliver a national cost collection index of 100, it doesn't necessarily mean that the tariff fully reimburses us for that, because of a range of adjustment factors that are used to derive the tariff. But it's some useful intelligence, and we can benchmark across other providers to get a sense of how we are performing. But how do we start to use some of that data? So next slide, please, Hack. Thank you. So actually there's some really rich costing intelligence across the organisations now, because we've been doing this costing returns for many years and really improving what we do and aligning that consistency nationally with how it's returned. So a really important thing is that we actually use some of that costing intelligence in our organisations, and so there's an opportunity as to how do we start to do that and to share learning and best practice. So one example of that is in the theatre's cost per minute. It was in the action schedule for group boards that we touched on earlier. And so what we're trying to do is use how do we use our theatre cost per minute, and how do we work with our COOs to really understand that we've got consistent and comparable metrics to compare. So are we actually able to compare them because we're counting it in the same way? And if we're confident that we are, how do we start to get into what's driving a variance in the differing cost per minute in each organisation? For example, we might find that where we've had significant vacancies in our theatres, or we've made use of a mobile theatre, for example, so Wye and George Eliot would certainly have those as challenges, that will have resulted in high costs in our theatre space, which will be driving a higher cost per minute. And as those things unwind, so as we employ more staff or we implement our elective surgical hub, we'd expect to see that cost per minute reduce. And it's one way that we can track what we're doing. And our COOs are taking this metric forward. So we're not saying that the numbers in here today are perfect. They need more work. We need to be convinced that they really are comparable before we start to delve into the so what. But it's an area that we want to start to get into more to make better use of our costing intelligence to support improvement. Last slide, please, Hack. So just to summarise across the deck then, so across the NHS, and it's no different for the group, the financial position this year is very challenged, and some of those key challenges impacting the position are consistent with the updates from our managing directors on performance in terms of emergency pressures, and also therefore that the CPIP that we touched on just a moment ago in Hack's update. There's good progress on planning and delivery, but there clearly remains risk in our financial positions. And if we look at productivity, there are various tools and metrics available to us that will help us get into understanding what's driving some of those cost increases across the group ahead of inflation, and the extent to which we can mitigate those moving forwards through improving our productivity. I'll pause there, Chair.
That's great, thank you, Katie. And those theatre costs per minute, I mean, Worcester being almost half George Eliot, I can't quite get my brain around that. So let's make sure the data is totally accurate. Questions and perspectives, then I'll move us on because we're close to running late. Catherine?
Yeah, I just wanted to say thank you to the people who've done the work to put that pack together and the next pack that's coming, because they really are helpful. There's a blizzard of talk about productivity and a blizzard of measures at the moment, and being able to see our organisations side by side, that again gives you some tangible examples of things to work on, is the purpose of why we get together in these board meetings like this. But I don't underestimate the amount of work it must have taken to get that data in a shape that it can be used by people like me. So thank you very much to everybody involved in that.
I do love the phrase a blizzard of data. And Glenn?
Yeah, I completely agree with Catherine's comments there. As part of the blizzard, there is about to be something called Learning and Improvement Networks launched across the NHS, which will look specifically at acute productivity, and will be bundled up in a West Midlands piece of work on that. And for a lot of trusts, actually, they don't have the opportunity to look at it in the way that we do here across groups. So it's really good to be ahead of the game on that.
Well, on the subject of getting ahead of the game, shall we dive in then to the elective productivity? And I think Andy and Harkamal, you're going to lead on behalf of all of the COOs. So over to you.
Thank you, Chair. I'm kicking off and ably assisted by Erica, who is driving the slides for me. Thank you, Erica. So I'm kicking off before I hand over to Harkamal. And yes, thank you, Catherine. I couldn't agree more in terms of how our information team, our operational teams and finance teams have pulled some of this information together. It is quite astounding from where we've come from even just a year ago in terms of pulling this information together so we can share and benchmark and learn from each other. So it's great work. So next slide, please, Erica. So I'm not going to read from the slides, they've been in your pack. I'm just going to go through the highlights here before I hand over to Erica. I think what is really pleasing here is all our priorities across the group in terms of delivering improved productivity. The same productivity about working smarter and more efficient. And across the foundation group, we're all part of the Getting It Right First Time Group B cohort, where we're sharing and learning not just from across the foundation group, but all the other trusts that are part of that group. And we're utilising and adopting all the best practice, not just what we're learning from each other, but also within the Getting It Right First Time handbooks that are a foundation for our transformational change and embedding and improving and getting our focus on getting the transactional delivery correct, but also that across the foundation group, we're all absolutely focused on maintaining that clear divide and separation between our urgent care and our elective pathways. Next slide, please, Erica. So this is our capped theatre utilisation across the foundation group. It really is pleasing to see that across the foundation group we are building on and stabilising our theatre utilisation, particularly over the last few months. There's lots more to go at, but we are all heading in the right direction. There is also common areas, if you look at our utilisation by specialty, where we're doing extremely well and we're benchmarking extremely well, breast surgery being one. And then there are other areas where we continue to learn in, try and deep dive across our operational groups and what's driving some of that variation in performance, particularly in ophthalmology and general surgery. Next slide, please, Erica. And then this is just a summary here of all the initiatives that are going on to improve our theatre utilisation across the group. Particular areas of focus across that are similar across all trusts are the high volume, low complexity lists, and we're all focused on particularly on areas such as ENT, and all areas are also focused on ensuring that we're delivering excellent theatre scheduling and reducing cancellations. We all know that 90% of successful theatre lists are and fully utilised lists are in the pre-op planning, the list construction and patient involvement and engagement, and that is throughout all the work that's going on across the foundation group in all trusts. Scheduling and sharing lists is list information and how we populate our lists is also a theme in terms of we are undertaking shadowing and reviewing across the foundation group. So we've got various teams dipping in and out of scheduling meetings across the trust to learn from each other. And we're seeing some of that improvements through our late starts and early finishes, and across the foundation group there has been a steady improvement in reducing our late finishes and reducing our late starts. Next slide please, Erica. And then cases per list, again, in some improvements here. There's a common theme here in terms of similar numbers in our ophthalmology cases per list, but there are also areas of good practice that we need to learn from each other, particularly at T&O, at George Eliot and Swift, and some of the operational teams are looking at that in a bit more detail in due course. Next slide please, Erica. And these are some of the initiatives that are ongoing currently in terms of improving our numbers on our lists, highlighting the schemes that each are focused on. There are similar themes here, particularly, as I already mentioned, on the high volume, low complexity lists. One of the other things is how our cataracts lists are being adopted and how we can learn from each other there. It's one challenge that we've all got across all of our trust, is how we improve our cataracts per lists up to the GIRF required level of 10 and 12 and beyond. And also learning through the implementation of our elective surgical hubs. Each of us are at various stages of accreditation and embedding delivery. And obviously, as already mentioned, the Wye Valley elective surgical hub went live on the 8th of July. Next slide, please, Erica. And then outpatient productivity, again, lots of improvements here across all 4 trusts, particularly our clinic utilisation, which is strong, with ongoing focus there on how we're scheduling and maximising our clinic lists in our outpatient setting, as well as ensuring that job planning and activity reviews are undertaken, both in medical and non-medical staff that are delivering outpatient clinics. New measure for this year is the percentage of our outpatient clinics that look at new and follow-ups with a procedure. The latest figure for across the foundation group is we are between 44.5 and 47.5%, and the regional average is at 43.6%. So we're above the regional average, but we do know there are trusts even within our region that are at 49% to 50%. So we absolutely need to learn from that. And then further work ongoing in terms of DNAs and where our teams can learn from that DNA challenges there. I'll come on to that again very shortly. Next slide, please, Erica. So PIFU, again, all trusts heading in the right direction with PIFU. Regionally, the average is 3.3%, and each of our trusts are heading in the right direction in terms of improving our PIFU offering, the use of digital systems to support our patients on these pathways. But we all have similar challenges in terms of how our clinical teams are engaged with PIFU and understanding the benefits of PIFU, and how we're using national and local data, and how we're using local and national promotional material, and our GIRF networks on how we improve and learn from others in terms of how we're delivering our PIFUs, but all the while keeping our eye on how discharge rates don't deteriorate just because we're putting patients on a PIFU pathway. Next slide, please, Erica. And then DNA rates, again, it's already mentioned, Worcester Acute are leading the way on our DNA rates across the foundation group. Regionally, DNA rates are at 7.7%, and all our trusts are way well below that regional average. But we know there's lots to go at, particularly that learning from that was already mentioned. And Adam mentioned what's happening at Swift and across the foundation group. We need to learn from that. These are the sort of 5 specialties that we've deemed to look at in particular detail, where we know there are certain trusts within our foundation groups that are performing with really low DNA rates, and those that are outliers, and further work and deep dive needs to go into that. Next slide, please, Erica. And here are some of the schemes that are going on in terms of driving down those DNA rates individually, but we're also linking in together. The ongoing use of digital technologies already mentioned in volunteers, but also how we use the upcoming patient portal that's just gone live in Herefordshire, how we can implement that to improve two-way messaging and ensure we can share information with our patients to drive down those DNA rates. And I'll hand over to Harker now.
I was going to say, Andrew, really comprehensive, fantastic, shows the enormous opportunity we have. When people say the NHS needs more money, that's true. The population increase in the UK has been enormous and will continue, which is wonderful. But the opportunity from productivity in the NHS, as demonstrated by those slides, is very, very clear. Harkamel, sorry, you're a bit short for time now, but over to you.
I'll be speedy. I won't go through these in details, but we've put just a focus set of slides together per trust, just to draw out some more of those issues and the drivers and some of the improvements. So Andy's mentioned some of these, but just to pick out the key things for George Eliot, the accuracy and reporting of usable data internally has been quite an issue. And so that's been a real area of focus for them. ENT capacity, and then that has a bit of an impact over at Swift. Has been a bit of a driver. The theatre planning tool that is under development, it's currently a manual exercise, so we can't underestimate the benefit that this will have. Of all of the drivers, the increase in cancer referrals, I think, is the biggest one to pull out, and that's common across the foundation group. And there have been some really important improvements that we have shared across the group. So Andy mentioned the 4 joints on the lists, but also the overall increase in volume on cases per lists in urology and general surgery, and the overall reduction in the backlog. For Swift, if we move on the slide, our orthodontic long waits remain an issue. So there are ones that are still flagging as very long waiting, and I've talked about those lots in Swift board. Our acute surgical admissions have risen significantly over the past 12 months, and that's been a bit of a driver in terms of how effectively we can use our theatres. And as has been referenced in the chat, our cataract numbers are below GIRFT expectations. And so we have spent quite a lot of time with Wye Valley trying to learn from them and see what we can do over at Swift to try and improve some of that. We have improved and maintained our theatre metrics for utilisation and productivity, so building on that remains a priority for us. Our endoscopy utilisation is strong, and so we're looking at how we can spread some of that learning across the group as well. And our waiting list backlog is reducing, albeit we do have some stubborn issues with some of the wait across the pathway. At Worcester, Andy references that the pre-op capacity is really a key issue. And so really making sure that teams are working on those pre-op processes to then sort out that start of the pathway and prevent cancellations on the day is key. And there's a large volume of patients on waiting follow-up lists, and the validation that's required of those patients is significant in terms of workload for Worcester. In terms of some of the drivers, we've mentioned it already, but that limited capacity within the pre-op is significant and a real area of focus. The services and case mix across the sites, there's an opportunity there in terms of one of the drivers, because at the moment the configuration isn't enabling the most efficient throughput. In terms of some of the improvements, the Worcester have launched a theatre programme works, well, they have been running a theatre programme for a while now with comprehensive work streams that are tackling these issues, as well as an outpatient programme. And then finally, at Wye, the ability to meet the 65-week and 52-week targets has been a challenge. And the challenge remains around the reliance on premium plus agency and waiting list initiatives to deliver some of that work. In terms of some of the drivers, reducing some of those unnecessary follow-ups and some of those long waiters in orthopedics, ophthalmology and ENT is clear. And in terms of some of the recent improvements, the job planning software to maximise clinical output is going to be really helpful over at Wye Valley, and we look forward to learning about all of that here. And also the review of the role of the clinical nurse specialists, as well as embedding the elective surgical hub. So just to sum up in terms of where we're going next, Andy referenced it, but we think that there's a bit more of an opportunity to look at some of our outpatient metrics and with specific attention to where our outpatients have a procedure, and obviously to continue to work together. But just before I hand back to you, Russell, you'll remember that about a year ago was when we first presented our theatre productivity data. And in pulling this presentation together, it sort of gave us a bit of an opportunity to reflect. And I think we all sort of felt that actually we have achieved remarkable progress. The data that you've seen in the pack, and I know it's already been referenced, but it is a lot more comprehensive. So all of that noise about comparing apples with apples is just sort of gone. So really grateful to our joint informatics lead who works across Foundation Group, who's worked tirelessly to make sure we're all saying the same thing and we mean the same thing. Because we've been able to benchmark against one another a lot more clearly, and that's driven really impactful changes that's supported by our teams, not just by reviewing the data, but actually like going to visit each other. So all our teams have visited each other, and I think there's definitely an open door across all trusts. But across that, just making sure that we're having that regular check-in. And it has been a real journey. We've established quite a robust set of governance around this, around all of our productivity initiatives. And we have regular weekly, in some cases, meetings to go through a lot of these programmes of work to make sure that we're driving forward with some of that change. And I think we felt that actually our approach of using the group to support our ideas and stuff is now embedded. It's not something that we drive as execs. We have one meeting a month now where a chief operating officer will chair it. But other than that, the weekly meetings are driven by the teams. And it's really gratifying, I think, to see that in terms of how our teams have come together to support one another. And so it's not as frightening now when you've got some of these really thorny issues, certainly for us at Swift to be able to come and ask someone to help us. And I think around your point, Glenn, those learning networks, it feels like we're already in one. So I think we're quite well placed to sort of grow and develop upon that, because as we heard this morning, that productivity challenge is only going to get harder, isn't it? So at least we've already started those conversations and we've leveled the playing field with some of the data to build upon.
Very well made points, Harkamel, and thank you, Andy, and everyone. Perspectives, Glenn?
Yeah, it's really great to see. It's always good to see the way you talk about each other's trusts as well, and that sense of buy-in from each of you. And it just helps to show, just the variation between the trusts is one thing, but then when you drill down the variation between the specialties within the trusts, and when you drill down again, the variation within the consultants within the specialties, there's huge opportunity for us to move up to a new norm of performance, and despite good performance across the board. So don't give up on your energy on this, please, Coos. I know you won't, but we do need to make sure that we capture some of those variations in the individual board meetings in terms of picking up on, why is it that a certain specialty has got double the DNA rate of the same specialty elsewhere in the group, and just try and get to the bottom of some of those solutions.
Absolutely, Glenn. And, if I can call out, for example, ophthalmology, with forbearance, Harkamel, I'll call out Swift ophthalmology. When we're not delivering the GIRF standard, I really do struggle to understand how, and I know there's lots of work going on behind the scenes here, I know that, but how our consultant colleagues justify their poor performance. And I think what's powerful in this analysis is our ability to just put out the facts as to whether it's poor performance or whether there are valid factors. But in big hitting and important areas like orthopedics and ophthalmology, we need to be at the absolute forefront of the pack. And as you said, the 80 cost reference of Swift is phenomenal, but it would be even better if ophthalmology was at the top of the pile as well. Glenn?
Yeah, and just to reassure any members of the public who may be watching this, there's a complementary piece of work going on in the background, which is led by Group Medical Advisor and Group Strategic Financial Advisor, looking at 6 specialties in each of the trusts that are outliers, and the Swift ophthalmology team are part of that process, just to understand the drivers for this. And sometimes it's not necessarily about the consultants themselves, it's about the arrangements in theatre facilities. So we're just trying to get to the bottom of what the blocks are so that we can remove them and improve productivity.
Absolutely, and always very willing to hear from any colleagues who can unlock these massive productivity changes. If you tell Harkamel, Glenn or I or Adam, for example, in Swift, what you need to do, we will be all ears, because we want those productivity improvements. Team, thank you very much. And as Jane has popped into the chat box, really great to see the early results coming out of that new elective hub at Wye Valley. We are bang on time, team, so I'll move us on, if that's okay, to an update on the Foundation Group objectives. Glenn?
Yeah, thank you, Chairman. So this paper is mainly to ensure that all 4 boards have seen the final objectives of all 4 trusts in the group. We don't set out to agree group level objectives. Obviously, we've got the group strategic direction and the big moves, and therefore a lot of these objectives link into those, but also link into the national and local productivity agenda and lots of other things that we're seeking to improve. So they're all there in the background. What I've also tried to do, which I no doubt get some comments on, is to try and identify the common areas where there's opportunities to share learning. So what we will seek to do is to join up the individual lead executives who are working on those objectives to share what they're doing with their counterpart elsewhere in the group. So I've used colour coding, Chairman. I've got a black and white copy of it in front of me, which doesn't help, which identifies some themes. So improving acute flow, improving system and place flow, supporting fragile services, digital maturity and digital productivity, prevention and tackling health inequalities, leading on carbon reduction, elective productivity, improving diagnostics and cancer performance, lead provider at place, developing research and teaching capability, flexible employer and retention, and continuous improvement. So you can see some great themes for improvement across group. And then beneath each of those, there's it's linked back to the individual trust objectives in those colours by trust. So please, executive leads, have a look at the ones that you're leading on, how I've grouped them, and do make contact with your counterparts elsewhere in the group if you're not already, and I know you are, because obviously we just this minute heard about some of those connections that are taking place. And the only reflection I'd give on this also is that in the various machinations that are going on nationally at the moment in terms of trying to look at another 10-year plan for the NHS and what the priorities might be, I think we're bang on the priorities, actually, when you look at the things that we're seeking to improve. So it's a good test of where we are as an organisation. So that's all I wanted to say, Chair.
No, thank you, Glenn, and I think you are quite right in saying we're bang on, that we're hitting the big targets that we need to for our citizens, but also coming out of the new agenda. Any questions to Glenn? Okie dokie. So banter going on about printers and default settings and saving a few quid, like to see it. We touched on the importance of inclusiveness and equality in the introductory remarks. We've got our equality update report. Not sure how colleagues, who's leading off on this, but over to you, Sarah, Ali and Jeffrey.
Thank you, Russell. I'll start us off and then we'll do a bit of a team effort and I'll take a few slides. I've taken the liberty of adding in an additional slide into the pack to just start us off with. Really, it felt quite timely in light of events and And as you mentioned earlier in your introduction, Chair, the recent events that we've experienced across the country. So it felt a good opportunity to just be able to update you all on some of the proactive measures that we're taking to support colleagues, and the very clear stance we're taking against racism and the riots and events that we've seen. I'll caveat that with it. This is a evolving piece, and even from writing this update this morning to give you today, things have been added and other things are taking place as we engage more with our colleagues and hear more about their specific needs, worries and concerns as well. So this work will continue to develop at pace, and we are continuing to talk as a Chief People Officer community and beyond to make sure that we're offering that consistent package of support to people. And I think probably the clear and most important message that we've been able to communicate to our colleagues is that clear position on zero tolerance, and that meaning that there is a willingness to withdraw treatment from patients that are racist, abusive, and also this clear disciplinary action towards any colleagues as well that have displayed those behaviours or attitudes in the workplace too. And alongside that, a willingness to report crimes and hate crimes to the police too, and work with community partners across the board. There is a considerable amount of additional support and communication going on right now, and much of that is being supported by our staff networks, but also working closely with our trade union colleagues. The BMA have published some helpful correspondence to trusts and their members this week as well about keeping safe and lone working, and working closely with our chaplains and multi-faith teams as well, who are supporting people with their concerns. Needless to say, and sadly, it also means we are needing to liaise with our security teams to just make sure that not only people feel that they know who they can go to if they're concerned about any activity on our sites, but also that we are very mindful and watchful of any behaviour that's of concern. And I didn't want to leave this without also just throwing in some of the positive ideas that have also been shared this last couple of days, and coming from our team at George Eliot, but this is catching on now, and we'll be doing this across the group. They are organising a Light a Candle for Peace event as well, and just discussing how we can mobilise that with colleagues too, so we can actually come together in solidarity to reassure all of our colleagues that we don't tolerate racism or this level of behaviour at all. Normal signposting to our wellbeing services is going on, but we are also working proactively around making sure there's some additional manager guidance to support colleagues, not least those that this will be very triggering for and may trigger PTSD from historical or other personal events in people's lives as well. So as I said, a moving piece there, and we'll continue to update individual boards respectively and keep in touch with each other as that goes on. The remainder of the presentation will just highlight some of the key areas of focus for each trust at the moment around equality, diversity and inclusion. This offers a very brief outline and key highlights of some of the areas we're focusing on at the moment, but it should be stated that each organisation still has their own equality, diversity and inclusion reports and their own individual response to race equality, disability equality and sexual orientation data and information as well. So this will give that very brief overview and some of the good practice that's going on. I'll hand over first to Sarah, who'll talk about Swift and George Eliot, and then we'll move through the other trusts as well.
Lovely, thank you, Ali. So at George Eliot, the EDI agenda and our priorities are really driven by our staff networks. So we're very fortunate to have 6 very active staff networks who work in collaboration with our EDI and engagement team to identify what our priorities are for creating an inclusive workplace for all. So I'll take the slides as read, but there are just a couple of things that I would like to pull out to highlight. So firstly, from our Armed Forces Community Network, we achieved the Silver Award for the Defence Employer Recognition Scheme in recognition of all the work that we've been doing alongside veteran organisations to support veterans and the families of serving personnel into employment, and working very closely with our Flexible Working Network as well to look at how we can support the families of serving personnel still to remain in employment with us. Our Embrace network and our Faith, Spirituality and Belief network work very closely together. And they have been looking at how we can improve that staff experience, looking at our res data and the areas for improvement, alongside the inclusive recruitment work that we're doing across the ICS, but also celebrating a range of events throughout the year, so celebrating the diversity that we have within the organisation. And then finally, we hosted Pride Month on behalf of the ICS in June. So we hosted that at George Eliot, had a great engagement from across the system, which was really positive. So moving forward then, our focus is on inclusion and belonging through inclusive recruitment and a number of campaigns. So including the Say My Name campaign, where we're encouraging everyone to have an audio recording of how to pronounce their name in their email signature. And also the Safe to Share campaign, where we're encouraging everyone to share any protected characteristics with us in confidence so that we can ensure that they're receiving the support that they need. If I move on to Swift, we've had a real increase in our staff engagement, so getting out, listening to colleagues and understanding what would make the difference to them. So as a result of that, we've now launched the Anti-Discrimination Help Desk. That's only just launched and it feels very timely with what's going on externally at the moment, and they're able to offer advice and support to staff in a really timely way. We're also very proud that our Workforce Disability Staff Network won the Midas Award, so the Midlands Inclusivity and Diversity Award for Network of the Year. And it was really fabulous to see that network's hard work being recognised in that way. Yeah, moving forward, one of the key things that we're doing is launching the Neurodiversity Staff Network, and alongside that, some neurodiversity awareness sessions to ensure that those staff with hidden disabilities are supported and feel that they belong at Swift. Swift is also going to be hosting Disability History Month later this year on behalf of the ICS. So our EDI leads across Swift and George Eliot continue to work collaboratively to share training opportunities, to share best practice and opportunities for improvement, and linking in with our colleagues across the foundation group to share those opportunities. So I will hand over to Ali.
Thank you. Apologies, I couldn't get off mute then. Okay, so at Worcestershire Acute Hospitals, I've just started to launch in the last couple of months work to redevelop and reconnect with our trust values, and our networks that we have been incredible in supporting that journey and continue to do great work in their respective groups as well. So they will be supporting that work going forward, as well as their other initiatives. And you can see a couple of them on the slide there. So we have our Rainbow Badge initiative, which is very positively supported by training and some really good work by the group there to publicise that across the organisation. In addition to that, we have launched recent Speak Up training as well, which again has had some very positive feedback from our networks in terms of supporting people to be able to speak up if they see behaviours or discriminatory behaviour of concern. One of the things I really wanted to highlight today was our supported internships programme. So our disability equality data has highlighted that we know this is an area that we need to focus more on. We need to do more in this area to support people into our organisation with various different needs and different abilities. but also make sure that we support that journey through work as well with the appropriate help, support and development for people. What Project Search do is specifically aim at 16 to 24-year-olds and supports people into employment with learning disabilities and different needs. We celebrated last month the graduation of 4 interns that joined us on placement. All 4 have successfully gained employment, 3 of them with our trust. 1 has actually gone into one of the feeder schools into the Project Search programme for permanent employment. And all 3 individuals are making an exceptional contribution to our services, the care we deliver to people, and in return, that this has given them that permanent employment with us as well. So are all valued members of our team. And it's through initiatives like that we can really make our equality, diversity and inclusion work come to life through those positive experiences. So that felt really important to celebrate and share as part of this as well. In terms of some of the next steps that we're taking, the values work that I talked about earlier will lead on to much more work around how we embed inclusive recruitment. We've got some fantastic training and development material there and support for people recruiting in an inclusive way, but there is always more to do. And I think underpinning that with the values work will be integral to that progress as well. But also importantly, we want to support people with resolution, and what this looks like in the equality, diversity, inclusion space is where people might struggle to get their reasonable adjustments, or may struggle to ask for help, or raise concerns if they're being treated unfavourably. So we have some planned work around that to support people to resolve their concerns in a variety of ways, and quickly to help them with their needs as well. Continued work with supported internships as well. And we'll continue to work with Project Search really positively and promote that work. And then excitingly, and supported by our charities as well, the creation of a new multi-faith hub at our hospitals, where we are connecting with multiple volunteers from a range of communities in Worcestershire to make sure that faith and spiritual support is there for both colleagues and for our patients as well when they need it most. Thank you. I'll pass on to Jeffrey.
Oh, thanks, Ali. Well, from our perspective, we all firmly believe that EDI is really about winning hearts and minds, not just about meeting your statutory obligations. So you can see from the examples that we are sharing that we are certainly trying to do that within all our 4 organizations. We also believe that it's important for our leaders to set the tone, to set the culture, to set the direction. And within Wye Valley, we're taking active steps in terms of promoting that compassionate and inclusive leadership. So we are actively encouraging all our line managers to sign up to the NHS Inclusive Leadership program and to act as role models within their respective departments to ensure zero tolerance of any discrimination, bullying, harassment, or victimization. Our staff networks are being sponsored by our exec director colleagues, and we're working actively with our trade union reps, our Freedom to Speak Up guardian and champions, just so we can have good relationships across the organization. If I move on to the next slide, through our education, training, recruitment, and health and well-being programs, we are also taking steps to enhance the working environment for every single person, and also to enhance our reputation as a good model employer of choice. So within Wye Valley, over the last 12 months, we've been working actively with the DWP and Job Centre Plus, and we are recognized as an exemplar organization. And through that engagement, we've employed, I think it's about 15 individuals now within the organization, and we will continue doing so. So it's about trying to reach out as an anchor organization to enhance and support the local population as well, and to really promote EDI things that we're doing within the trust. If I move into the next slide, this just talks about some of the things that we will continue doing over the coming year. because we know that equality, diversity, and inclusion is the right thing to do. We now have a more diverse workforce than at any time in our history. So it's incumbent upon all of us to ensure that we take in the right steps to promote and support equality, diversity, and inclusion. So this just tells you some of the things we'll be doing over the coming year, but the board can be assured that we taking our EDI obligations and responsibilities very seriously and will continue to do so. And over the last 2-3 years, we can now see we are seeing improvements in our staff survey results. When you look at across all 4 organizations from an EDI perspective, we're seeing some really, really good progress on those metrics within the staff surveys. So as I said, across the board, we're working in collaboration. We'll continue doing so, and we will ensure that EDI remains at the center of everything we do. Because if you get EDI right, then everything else falls into play in terms of motivation, morale, and staff engagement. I think that's the end of the presentation, Russell. We're happy to take any questions.
No, super. Thank you, Jeffrey. Sue makes an important point in the chat box regarding circulating the full EDI reports. And your points are well made, Jeffrey. And I'll just emphasise a point before I go to Glenn. EDI, inclusiveness, respect are personal challenges as well as organisation and corporate challenges, and it's why it's really important for us to keep this near the top of our agenda, as we do, to make sure we hold ourselves to the highest standards of behaviour and improvement. Glenn?
Yeah, in these incredibly worrying times for the country, it's really reassuring to see what we're doing around EDI. And I mean, not just as an employer or an organisation that treats patients, but as an anchor institution, because I actually do think we are uniquely placed as an NHS to try and change attitudes. Russell said some great words at the start of the meeting, but I mean, I spoke out on Twitter about racism, and someone comes back to me hiding behind social media to say, I'm taking a political stance. I shouldn't be taking a political stance. Being anti-racist is not political. It's a human right. And we need to absolutely make sure we use our anchor institution credentials to really start to shift the balance on this. So well done for all of the people, teams that are on the agenda and all the other execs that are on this as well. So it's good. It's reassuring to see the action.
Yeah, this is a moral issue. It's wrong to be racist. It's wrong to be sexist. It's wrong to be a bully. It's right to treat people with respect. It's right to be inclusive. It's right to focus on every individual and celebrate them. Apologies for the dogs in the background. But for me, this is a moral issue. It isn't just a tick box exercise. Catherine, and then we'll move on because we're running a few minutes late now. Catherine.
Yeah, I just would like to re-emphasise that point about this is not something that is being done in response to the national event. This is because, as you have just said, it's the right thing to do, that a diverse team is a stronger team. And we are better at responding to some of the events that are going on at the moment because we are blessed by working in a diverse team. And I think our staff need to hear that from us. They need to see it in our actions, and how we respond to this is about the character of whether our words mean anything. And I think it's just really important that our staff, the public, know that we are serious about treating all of the people in our team equally. So I just wanted to re-emphasise that.
No, thank you, Catherine. Good discussion. Look forward to seeing progress on that. But Ali, Jeffrey, Sarah, if there's anything more you need Glenn and I to do, or any of the leaders, please just reach out to us and let us know. I'll take, just for information, the committee report from the meeting held on the 16th of July. Any questions on that, team? Can't see any digital hands raised. So any other business from directors before I go to questions from members of the public? Any other business? Okay, so Sarah, have we had any questions notified to us from members of the public?
We haven't, no.
We've got a few members of the public with us. Are there any questions you'd like to ask us? Please raise a digital hand. Okay, I can't see any digital hands being raised. I'd just like to thank members of the public for joining us again. And can I suggest, colleagues, that we meet in 10 minutes at 3:25 for the confidential agenda. See you in 10 minutes. Thank you, everyone. Take care. Bye-bye.